To begin with first slide, what we can see over here is the most modern evolution of technology. We can see the series of mobile phones which has evolved over a period of last 3 decades. What I wanted to emphasize is that the technology is evolving with time, but we as a medical personnel have conservatism for various things. I myself took almost 3 to 4 years to switch from a routine phone to a touch keypad phone. So what I mean to say is, because the technology is evolving fast, we need to keep up pace with the technology and learn new things. If you stay with your conservative behavior, then it will be difficult for you to learn. So what does this slide gives us the message? It gives us a message that any medical personnel with a reasonably good anatomical orientation of the human body can become one of the best ultrasonographer in this world. So we will begin our journey with learning of the echocardiography machine. So what is echocardiography? Echocardiography basically is the ultrasonography of a beating heart. And the echocardiography machine has 3 components. When we see the machine, it has a monitor or a display, the keyboard where we can play with the various functions of the machine, and the probes. There are 2 types of machine. One is a standalone machine and the another is a portable laptop type machines which are available in the market. Now, what is the basic principle of ultrasound machine? Ultrasound machine emits sound waves. Because of the frequency of the ultrasound, sound wave is very, very high. It is known as ultrasound wave. The ultrasound machine emits frequency of as high as more than 20,000 hertz. Human ear can listen to the sound waves with frequency ranging from 20 hertz to 20,000 hertz. And after 20,000 hertz, the ultrasound starts emitting the ultrasound waves. So we will not be able to listen the ultrasound waves which is emitted by the ultrasound machine. There are various animals and mammals who have the extra ability to hear high frequency sound, the highest being with the dolphin, who can hear up to 200 kilohertz of ultrasound. So how does the ultrasound machine works? What we can see over here is the probe. What happens that there is a crystal, a disc-like crystal situated at the tip of the probe, and that crystal is known as piezoelectric crystal. When the electrical impulse comes into the probe and stimulates these piezoelectric crystals, these piezoelectric crystals will emit ultrasound waves, and these waves transmit in the solid media, that is to our body. Depending upon the type of quality of the piezoelectrical crystals, a different type of frequency of ultrasound waves are emitted from these piezoelectrical crystals. And depending upon the density of the various structures in the body, these sound waves will travel to the distant organs. And this frequency gets absorbed to some extent, and some extent it will get reflected. So because of the process of some absorption of the ultrasound waves and reflection of the remaining waves, these waves return back and creates an image on the screen. What we can see on the display. So this is the basic principle of any ultrasound machine. There are various types of probes available for use of various organs. Like for the heart, we have sector probe. For the vessels, we have linear probe. For the solid structures in the abdomen, we have curvilinear probe. For transesophageal echocardiography, we have echocardiography probe, and even we have intracardiac echocardiography probe, which can goes to the blood vessel. So there are various probes available for various organs which can show the ultrasound image on the screen. We will be discussing ultrasound probes used for echocardiography. For echocardiography, we use sector probes. Sector probe means it gives a triangular structure on the display screen. There are three types of cardiac probes: the neonatal probe, the pediatric probe, and the adult probe. All the probes can generate sound waves and create pictures on the display depending upon the resolution and the penetration power. So what is resolution? What is penetration power? Resolution means ability to see two structures as two separate structures on the screen. What has been suggested that if you want to see two nearer structures with a high resolution, you need to have a high frequency probe. The neonatal probe has the highest resolution. It means that if you are using a high frequency probe, it will show a good resolution. The probes with higher frequency disintegrate early, so the penetration power is less. And the probes with lower frequency have a higher penetration power. So the high frequency probes are good for neonates and small babies where the penetration power is not required and good resolution is required. So even smaller structures can be seen with more clarity. The low frequency probes have a deeper penetration, hence they are good for adult and big children. This is one of the example. What we can see here is a high frequency probe and here is a low frequency probe. What we can see here from this is a sector and the penetration power is up to 30 centimeters. But in case of pediatric probe, the penetration power is up to 15 centimeters. So the high frequency probe will have a less penetration power and the low frequency probe will have a higher penetration power. So here we are having a differentiating feature. Higher the frequency, higher the resolution. You can see two structures separately. So in neonates where you have a smaller valves, smaller structures, we will be able to differentiate and have a clear picture in small babies. So resolution is high in high frequency probe. In the medium frequency, you have medium resolution, and in low frequency, the resolution is less. Because the frequency is high, the penetration power is less, so the depth penetration is less with the high frequency. The medium will have medium depth penetration, and the low frequency probe will have the highest of the penetration. Even for the color Doppler, we have a low frequency, we prefer low frequency probe. It will give the maximum color output. The high frequency probe will have a smaller footprint. The medium frequency will have medium and the low frequency will have a larger footprint. So this is basically the keyboard. The most important things we need to understand as a beginner is these four keys: 2D or two-dimensional, M mode is the motion mode, the color Doppler, the pulse Doppler, and the continuous wave Doppler. These are the 5 keys which are very important for us. There might be various keys on the keyboard, but this to begin with, let us focus on these 5 modes of echocardiography. The first mode which came into existence is the motion mode. Then we have the two-dimensional mode. Then we have the Doppler modes, the continuous wave Doppler, the pulse Doppler, and the color Doppler. So what I have discussed here, the first mode available for clinical use was the motion mode. So what is motion mode? It is a single crystal, single dimension beam, and the path of the beam displayed on the movable cursor. The beam stationary within the sector with the cardiac contraction and the movement of the heart will show a graphical motion of the various structures on the screen. For example, this is the probe and this is the cursor. This cursor is a stationary cursor once you put it in this direction. You can move the cursor to different level, and once you stabilize the cursor at particular point and you press M mode, what you will find is the picture in a single dimension beam. So what a single dimension beam will be seen with the cardiac cycle is this type of structure. So this structure denotes only this particular area. This structure denotes this particular area, and across the valve, it will denote this particular area. So this is the cursor across the long axis of the heart, where we are cutting the heart at the level of right ventricle, the interventricular septum, the left ventricle, the mitral wall, and the posterior wall of the left ventricle. So this is what we are seeing is the diastole, where the heart is relaxing. That is both the walls of the left ventricle are moving apart. Here we are seeing the systole, that is both the walls of the left ventricle are approximating each other. Systole means contraction of the heart and diastole means relaxation of the heart. So this is the relaxation portion of the heart where the heart is moving apart, and this is the contraction portion of the cardiac cycle where the heart is moving towards each other. What we are seeing, this structure is the opening of the mitral valve, and now during the systole, the mitral valve is closed. Again, in the diastole, we see the opening of the mitral valve, and then it is closed. So mitral valve has two leaflets, the anterior mitral leaflets and the posterior mitral leaflets. What we are seeing over here, with the, as we know, the cardiac cycle has in diastole has early rapid filling phase and the atrial contraction phase. So what we are seeing first wave is because of the early rapid filling phase, what we call is that E wave. And then we have the atrial contraction wave, that is the A wave. So this is the normal characteristic pattern of opening of the mitral valve on M mode. Now coming to the cursor beam, if the cursor is shifted to the aortic valve and the left atrium, what we are seeing over here is the diastolic closure line of the aortic valve, and now the aortic valve is opening, and this is the anterior cusp and this is the posterior cusp. Again, it closes after the systole is over, and now this diastolic closure line. So in systole, the aortic valve will open and again it will close. So this is what we see, the movement of the aortic valve as well as the mitral valve. How does it see? Is seen on M mode. So this is the live picture of the echo of a left ventricle long axis. What we are seeing over here is this is the diastole, and then the systole, So it's the right ventricle cavity, the interventricular septum, the left ventricular cavity, the posterior wall of the left ventricle. And this is the opening of the mitral valve, and then it is closing at the systole. The ECG and pulse tracing recorded simultaneously help facilitate the time relationship with these variables with the cardiac activity. So when we correlate ECG with the cardiac function, cardiac cycle, what we can see over here, the QRS of the ECG denotes ventricular depolarization, means once the ventricular depolarization happens, there will be systole. So after this point, what we can see over here is the systole. And after that, there is a diastole. The atrial contraction correlates with the second phase of the opening of the mitral valve. So what is the utility of the motion mode? It was the first mode which came into the existence before the 2D and the Doppler were there. So with the help of motion mode, majority of the cardiac function was the first thing which was the utility. The cardiac dimension, whether the cardiac dimensions are within normal limit or not, were assessed with the motion mode. The cardiac function, what is the left ventricular systolic function, can be assessed with the help of motion mode. And for this, we need various parameters like the thickness of the wall, the chamber size, the vessel size, and the fractional shortening. Fractional shortening is an index of measuring the cardiac function. The other function of the motion mode are opening and the closing of the mitral valve will help us diagnose various conditions like mitral stenosis, mitral valve prolapse, pulmonary arterial hypertension. The movement of the interventricular septum and the valve will help us diagnose conditions like systolic anterior motion of the mitral valve. The anatomy of the valves can also be assessed by the motion mode. The pericardial fluid can also be diagnosed. And in fetal echo, the arrhythmias can also be diagnosed with the help of motion mode. The various dimensions pertaining to age are given in this nomogram. Once you start doing it, you will remember on the own. And these are the various dimensions based on the weight. These are the dimensions based on the age and dimensions based on the age. Either of these you can follow. So what we are seeing over here is the same thing, that in the motion mode, if the cursor passes through the left ventricle at the papillary muscle level, you will see these type of images. At the level of mitral valve, you will see these type of images where the mitral valve is opening and the closing. And if the cursor is passing through the aortic valve in the left atrium, you can see the opening and the closing of the aortic valve. What is fractional shortening? The fractional shortening is the fractional change of the left ventricular dimension from the end diastole to the end of the systole. So the fractional shortening is given by this formula. How this formula has come? The left ventricle end diastolic dimension, if the left ventricular end diastolic dimension is 100%, then the change in the left ventricular end diastolic dimension to the end diastolic systolic dimension in percentage will be the fractional shortening. The fractional shortening is normally mean of 36% with 95% prediction value from 28 to 44%. If this value is less, it means the left ventricle is poorly contracting. If this value is more, it means the left ventricle is contracting very well. Similarly, ejection fraction. The ejection fraction is similar to the fractional shortening, but this is the index measure of volume, the end diastolic volume, while the fractional shortening is a measure of dimension, end diastolic dimension. So it is measured in millimeters, it is measured in ml. So it is the same thing, the amount of blood which is present in the heart at the end of diastole and at the end of systole, we get ejection fraction, which the mean value is 74%, ranging from 64 to 83%. Ejection fraction and fractional shortening are one and the same, and it does not offer any advantage over the other. So in this patient, what we can see over here is the end diastolic dimension is 59, and from 59, the end diastolic dimension went to 54, which means that from diastole to systole, the heart has moved this much in terms of dimension, and hence the fractional shortening is only 8%. So it is calculated by the machine. If you calculate with that formula, it will come the same. Now, in this particular case, the left LV end diastolic dimension is 46, and the LV end systolic dimension is 28. From 46, it has come to 28. Hence, the fractional shortening is 37%, so which is within normal limit. From M mode, you can also calculate the left atrium aorta ratio, which will also give you a clue whether the left atrium is dilated. So when you measure the aorta and you measure the left atrium and you get the LA aorta ratio, if the ratio is more than 1.5, it means that the left atrium is dilated. There are various volume overload conditions like mitral regurgitation, patent ductus arteriosus, ventricular septal defect. You will see that the left atrium is dilated. So in those cases, the LA aorta ratio will be altered. Now coming to the another type of picture is the paradoxical septal motion. What we have seen in the previous M mode data, that in diastole this moves up and on the opposite side it moves down. But what we can see over here is both are moving in same direction. When both are moving in same direction, similarly in diastole this is also moving up, this is also moving up. In systole this is moving down, this is also moving down. So this is almost a parallel rather than circle. It is not forming a circle, it is more parallel to each other. So this type of scenario is known as paradoxical septal motion, and it is seen in ventricular dysfunction, cardiac tamponade, constrictive pericarditis, and in patients with RV dysfunction, which could be because of pulmonary stenosis or pulmonary hypertension. Now coming to the most important mitral stenosis that we see in adolescent kids. In mitral stenosis, what is happening is there is thickening of the leaflets. So because the leaflets get thickened, there is reduced in the mobility of the mitral valve, and there is commissural fusion. So as a result of which, the posterior mitral leaflet mobility is reduced significantly, and when the valve is trying to open up, it is not becoming open up, but it is pulled anteriorly instead of being pulled posteriorly. So this is the normal movement of the mitral valve, what is denoted by the E wave and the A wave. Ideally, it is E, D, E, F, A, C. So this is the anterior mitral leaflet, and below what we are seeing is the posterior mitral leaflet. The first E wave is the early rapid filling of the ventricle, and the second A wave is because of the atrial contraction. So this is the EF slope, which normally we see in normal patients. But in case of mitral stenosis, what will happen? That there will be poor mobility of the posterior mitral leaflet, and hence this leaflet will move anteriorly. And because this is the movement of the anterior mitral leaflet, this is the movement of the posterior mitral leaflet, this is also moving anteriorly, and the EF slope has reduced. So reduction in the EF slope with paradoxical anterior diastolic motion of the posterior mitral leaflet is characteristic of mitral stenosis. But if this, what we are seeing here is we have a sinus rhythm. We are getting the ventricular contraction at a regular rate. But mitral stenosis is almost always associated with atrial fibrillation in severe cases. So in atrial fibrillation, it is the opening of the mitral valve may not happen in few cycles. We can see here the mitral valve is opening, here the mitral valve is not at all opening. So this is suggestive of severe mitral stenosis. Now coming to the type of valve, how can we diagnose the valve is bicuspid? The diastolic closure line is in the center with the aortic lumen. in tricuspid aortic valve. But this diastolic closure line moves eccentric in presence with bicuspid aortic valve. What we can see over here is the classical tricuspid valve, and this is the bicuspid valve of three different types. Then this commissural fusion happens in 2 o'clock position, 10 o'clock position, and this is 3 o'clock position aortic valve. So in this particular case, if we have a cursor across this valve, you will see a diastolic closure line in the center, exactly in the center of the aorta. But if the diastolic closure line moves on the either side, not in the center, then it is suggestive of bicuspid aortic valve. In few cases, you may have a multiple diastolic closure lines also. So this is an example where we can see that we have a diastolic closure line in the center, but in this particular case, the diastolic closure line is shifted upwards, which means that this is a bicuspid aortic valve. Similarly, for pulmonary hypertension, sometimes it is difficult for us to get the tricuspid regurgitation jet. So the PA pressures can also be assessed by M mode of the pulmonary valve. So what is the normal M mode of the pulmonary valve? We have a systolic closure, diastolic closure of the pulmonary valve, that is EF. And then because the atrial contraction, you have a notch, and then the pulmonary valve opens with the systole. Then whole of the ejection happens in the first few seconds, and gradually the pulmonary valve closes, and then you have the closure of the pulmonary valve. But in patients with pulmonary hypertension, the pressure is high over here. Because of that, this aortic notch will disappear. So we will have a straight disappearance, and the EF slope has also steeped up. The slope has reduced. And because the pressure is high, you will have a systolic notch in the opening of the pulmonary valve. This we will see over here. What we are seeing is this is the diastolic closure of the pulmonary valve. This is the opening of the pulmonary valve against the closure. So this is the A notch, which is present because of the aortic atrial contraction. But here, sorry, I just wanted to ask, everybody can see the cursor which I am moving? Can everybody see this cursor which I am moving? Yes, mouse sir. Cursor?
Yes, sir, we can able to see.
You can see the cursor. Okay, thank you so much. So in this particular case, there is absence of the A wave, and the EF slope has also reduced, which denotes that there is a pulmonary hypertension. Also in fetal echocardiography, it has a major role in diagnosing the arrhythmias. So this is the fetal echo of the heart, where we can see that the cursor is passing through the ventricle and the atrium, and the speed of the heart is too fast. But the speed of the ventricle as well as the speed of atrium, both are equal. So that is 1:1 conduction is happening. So when the ventricular and the atrial rates are high with 1:1 conduction, it is known as fetal SVT. But in this particular case, what we can see over here is the atrial speed is high, but the ventricular speed is low, which means that there is a block, 2:1 block, and it is seen in atrial flutter. The atrial speed is high, so it is atrial flutter. Post-pericardial effusion can also be easily seen with the M mode. In this particular case, LV long axis, what we can see over here, during systole, there is some amount of pericardial effusion which we can see over here. This is the posterior wall of the left ventricle seen on M mode. During diastole, there is no effusion, but during systole, there is some amount of pericardial effusion which we can see. A small pericardial effusion will be seen only in the systole. And in this particular case, we can see the pericardial effusion both during systole as well as in diastole, and it is a massive pericardial effusion. Now coming to the two-dimension mode. A single line of image is produced in M mode. And when all these single line unite in one plane, it will give image which is called a two-dimensional echocardiography image. And this typical image is formed by union of 128 lines of information. But now with the updation of various echocardiography machine, this number has increased. Just like in CT scan, we have 16 slice, 24 slice, 64 slice, 128 slice. Similarly, the basic lines which we need is 128 lines. And now with the help of various technology, like few companies uses matrix technology, few companies uses a single crystal technology. So these lines are increased, and which will increase the resolution power as well as the penetration power. So what we see in 2D is the sector of information. This sector of information in 2D has the apex, has the base, and here is the sector. So this is the apex and this is the base of the sector. And this is what we are seeing is the depth in centimeters. This is a 5 centimeters, this is 10 centimeters, this is 15 centimeters. So what we see in 2D is a two-dimensional moving heart. This is a moving heart that we are seeing in 2 dimensions. But in case of M mode, what we see is a still heart which moves only in one frame. So regarding the 2 dimension, we will discuss later in all our 3 to 4 lectures. But just to give idea that this is 2D, which is a moving heart, we will come to the color Doppler. So what is Doppler technology? Doppler is an non-invasive technique which gives us information about the direction of the flow of the blood, at the same time the velocity of the flow of the blood. The Doppler echocardiography can give us valuable information even without any invasive monitoring. So what is the principle of Doppler? It is the same sound waves. When we hear the sound of a car, our ears have the capability of understanding whether the car is moving towards us or the car is moving away from us or the car is stationary. The same function the echocardiography machine does for us and tells us whether the blood is moving towards the probe, whether the blood is moving away from the probe, how fast the blood is moving towards the probe or the away from the probe. So it will give us the direction as well as the velocity of the blood. So this is what we are seeing here, two images where we have a laminar flow and the turbulent flow. What is a laminar flow? When all the particles of the blood moves with same speed in same direction, it is known as laminar flow. In our body, the maximum velocity that we can measure is 1.5 meter per second. But in this particular case, the velocity is laminar till this point. But now there is a narrowing at this point and whole blood has to go through this narrow point, as a result of which there will be turbulence flow. The velocity at this point will increase and hence this flow is known as turbulent flow. So the Doppler will help us identify whether the flow is laminar or turbulent. So in this particular, this is a heart photograph where we can see that there is a laminar flow across the valve. But in this particular case, the valve is stenosed, and because of that, we have a turbulent flow across the valve. So Doppler, what does it measure? It measures a relative change in the returned ultrasound compared to the transmitted frequency and helps us diagnose the direction, velocity, and differentiate between the laminar and the turbulence flow. It helps differentiate the normal as well as the abnormal flow. All the Doppler systems have audio output changing velocities are converted into audible sounds. High-pitched sound result from the large Doppler shift and hence indicate presence of high velocity, and low-pitched sound result from a lesser Doppler shift. So when you hear a large sound generating from the machine, it usually means that the velocity is high. It is just a correlation, but you can switch off the volume also. Now, regarding the direction, the flow velocity towards the transducer is displayed a positive up or upward shift in the velocity. Anything which is moving towards the probe is seen above the baseline, or anything which is moving away from the probe will be seen below the baseline. And this baseline is a time axis. What is the angle effect? We will not go into the details of this cos theta, but what I wanted to emphasize is from the probe, there is a sound beam that hits the heart or the vessel. And this sound beam should have the minimalistic of this angle. If the angle is more, the velocity which we can measure will be false. We'll have a lot of inaccuracy. So this is one example. What we can see over here is the cursor and the direction of the flow. Here we have only 10 degrees, and hence we can get the best possible velocity. As the angle increases, the velocity is decreasing. Actually, the velocity, this is the true velocity which we can measure. So what I mean to say is, when we are trying to measure the velocity of the blood, the jet of the blood and the cursor should have a minimalistic angle. If the angle is more, the results cannot be accurate. So the Doppler types are the pulse wave Doppler, the continuous wave Doppler, the tissue Doppler, and the color Doppler. So what is tissue Doppler? Tissue Doppler has a limited use in pediatric. It assesses the velocity of not the blood, but the myocardial cells. The moving target in this case is the myocardium and not the blood. So it has a higher amplitude and lesser velocity. Coming to the continuous wave Doppler. What is continuous wave Doppler? Continuous wave involves continuous generation of the ultrasound wave, and it measures the velocity across the whole beam of the sound. This sound beam, it will measure the velocity at each and every point. So you will get the minimum velocity blood flow also, and you will get the highest velocity blood flow also. So each and every point is measured in a continuous wave sound beam. In case of pulse Doppler, what happens that only a selected area is notified, what we call a sample size, and in that particular area only the velocity is measured. So this is what the blue color jet is called the sound beam, or what we see as a cursor on our 2D screen. And this cursor, if we select a particular area and press pulse Doppler, you will be able to measure the velocity only in that particular point. But if you press a continuous wave Doppler, you will measure the velocity across the whole length of the cursor. So in pulse Doppler, the sample volume will be very small. But in case of continuous wave Doppler, the sample volume will be across the whole length of the sound beam. So what are the implications? What are the uses of pulse Doppler? It helps assess velocity across the normal valves as well as the vessel, and helps to calculate cardiac function and flows. Continuous wave Doppler helps to measure the highest velocities across the restricted orifices like stenotic or the regurgitant lesion. And these velocities can be converted into pressure gradient with the help of Bernoulli's equation. So what we can see over here is the continuous wave Doppler across the aortic valve, and this is the continuous wave Doppler signal which we are getting over here. What is the characteristic pattern of pulse wave Doppler? Normally, the majority of blood cells moves with same velocity in same direction, and hence the most brightest portion of the spectral is seen at the outer edge of the graph. All the blood is moving in same direction at same velocity. So you will see the brightest portion only at the border or the upper part. This whole thing is black. Here there is no blood. Only the blood is moving in this brighter zone. But in case of continuous wave Doppler, what happens? That you have a full spectral envelope. The blood with lesser velocity is also taken up. The blood with the highest velocity will be at the periphery. So you get the maximum velocity. So to get the highest velocity, you need to have a continuous wave Doppler. So what is color Doppler? The color Doppler is basically the shifts which is assigned color to the RBCs. If the RBCs are moving towards the probe, it will give red color. If the RBCs are moving away from the probe, it will give blue color. And if there is a disturbed flow, it will give a third color, which could be green, yellow. The intensity of the color which indicates the velocity. So what we can see over here is the red blood, which is moving towards the probe, and now the blue blood, which is moving away from the probe. The red blood does not mean oxygenated, and the blue blood does not mean deoxygenated blood. Red blood means the blood which is moving towards the probe. The probe will be at the apex of the sector at this point. So now this is an example of superior vena cava flow. What we can see over superior here is we have focusing on the superior vena cava through the subcostal view, which is seen as red. But now the same superior vena cava we are focusing through the suprasternal view, which is seen as blue. So the red and blue has nothing to do with the oxygenation of the blood. It has to do with the whether the blood is moving towards the probe or the blood is moving away from the probe. So finally, CW or the continuous Doppler is used for the higher velocities. The PW is used for specified locations. Color Doppler is used for the disturbed flow as well as to see whether you have an eccentric jet or a central jet, and also to assess the severity of various valvular and stenotic lesions across the valves. Now coming to what is, we will take only one example, superior vena cava Doppler. So because in superior vena cava we have a laminar flow, we will use pulse Doppler, and this pulse Doppler will give this characteristic pattern, what we call it S wave, D wave, and A wave. S wave is because of atrial relaxation. The D wave is because of atrial contraction, because of ventricular relaxation, and A wave is because of atrial contraction. So this is a normal pattern which we see in superior vena cava flow. The similar pattern will be seen in inferior vena cava flow. Now we will have some examples where we will see all the modalities, 2D, color, Doppler, everything. This is the 2D where we can see the fourth chamber of the heart. This is the interventricular septum, and there is a rent in there is breach in the continuity of the interventricular septum at this point. Here we can see this is the interventricular septum, this is the aorta. The interventricular septum is not continuous with the aorta. We are seeing a breach. So this breach is known as VSD. So the same thing, now we are putting a color on it. And what we can see over here is there is a jet coming from the VSD, and the VSD jet is red in color because it is coming towards the apex, that is towards the probe. Here also we can see the red jet because this VSD jet is moving towards the probe. In this long axis case, the same thing which we are seeing, and now we are putting a cursor at this particular point, And now we are measuring the continuous wave Doppler and getting the velocity. So what we are seeing over here, the velocity is 420 centimeters per second. And if we convert it into the gradient with the help of Bernoulli's equation, it is 71 millimeters of mercury. So this is the 70 millimeters of mercury means that the pressure difference between the left ventricle and the right ventricle is 71. Now coming to the PDA, what is PDA? PDA is an anomalous connection between the aorta and the pulmonary artery. Here what we can see here is a continuous flow. This is the short axis of the PDA and this is the long axis of the PDA. And this PDA jet is red in color and because it is towards the probe. And at the point of narrowing, it is showing green color. It means that this green color is the point of maximum velocity. And now putting the continuous wave Doppler, what we can see here is a continuous Doppler pattern, continuous wave on the screen. The maximum systolic velocity, which was measured as 68 millimeters of mercury, and the velocity at the end of diastole is 38 millimeters of mercury. In this particular case, the PDA is also seen, and there is turbulence at the pulmonary wall also. So if you put this on the Doppler, you will see both the things on the either side of the time axis. Because the PDA is red, it will be seen above the baseline, and the pulmonary stenosis is blue, it will be seen below the baseline. So this Doppler tracing is of pulmonary stenosis, and this continuous Doppler is of patent ductus arteriosus. Now, in case of aortic stenosis, this is a two-dimensional where we can see that the aortic wall is doming; it is not opening completely, and this is the aortic arch showing the jet of the pulmonary aortic stenosis. And if you put a cursor across the jet of aortic wall, we will be able to see this Doppler image of the stenosed aortic wall, where the maximum velocity which is 64. The velocity of 64 across the aortic wall means that the pressure difference between the left ventricle and the aorta is 64. Now coming to the aortic pulmonary stenosis, the similar pattern we can see over here. This is the subcostal view, this is the parasternal view. And the same pattern we will see because it is blue in color, it will be seen below the baseline. Similar in mitral regurgitation, there are two types of jet which we can see is the eccentric jet and the central jet. In this particular case, the jet is hitting the lateral wall. So this hitting the lateral wall is a eccentric jet. When you have eccentric jet, it means that one wall is affected. When you have central jet, means that both the walls are affected. So this is a central jet in case of aortic regurgitation. And this is the eccentric jet in patients with aortic regurgitation. The pressure half time is the time taken by the blood to reach is half the velocity of the peak velocity. And that will give you the severity of aortic stenosis, aortic regurgitation also. In mitral stenosis, the hockey stick appearance is seen on 2D, which is suggestive that the aortic stenosis is of severe variety. And based on the EF slope, you can calculate the mitral wall area. Because of aortic stenosis, you can see over here that this is the black blood, this is the black blood, but here the blood is slightly anguished, and this is because of the spontaneous, the blood is slightly bit thicker, clotted. Because of the aortic stenosis, it is known as spontaneous echo-contrast. This is a rare image of bicuspid double orifice mitral valve. We can see that there are two openings of the mitral valve. So now coming to the last part, how to optimize the image quality. If you are doing an echo and your image quality are not good, naturally, if you are as a fresher, image quality is not good, so you are not happy and you lose interest. See, the image quality is not good, I am not able. So there are few basic principles that you need to know. Selection of the probe. Select high frequency probe for small babies and low frequency probe for the larger babies. For high velocity, select low frequency probes. So this is an adult probe and this is a pediatric probe. You can see that the structures are seen very well in the second image, but in this particular case, the structures are more denser and the clarity of the valve is not much. Here, the valve clarity is too good. So this is the high frequency probe and has a good resolution. The penetration is poor, they're up to 6 centimeter, but the penetration over here is up to 15 centimeter. Similarly, the adjustment of the depth. Adjust the depth so that the cardiac structures accommodate at least 2/3 of the sector area. See, if you see the heart structure like this, at least it should accommodate the 2/3 of the sector area. Gains. Gains have to be adjusted such that the blood should become black and the cardiac structures should be white. See, this is more gain. Now this is less gain. This is under gain. So you have to fix this gain to such a level that you see that the blood is black and the heart structure is white. Adjust the focus of the sector at a point of interest for better. Like if you are interested in VSD and this is the focus, this particular point has to be adjusted with the help of knob given on the keyboard. Whatever place you will keep, it will show that particular area will be highlighted better. Size of the 2D and the sector. So if the heart is small, why to keep such a big sector? You can narrow the sector size so that you can get a more clearer image. Similarly, it is true also for the color also. Why you want such a big color sector if you want to only see the mitral valve? So this reduce the color sector to a smaller size. Change of posture. In bigger babies, it is very difficult to get the images because the heart is away from the anterior chest wall. So turning the patient to left lateral will bring the heart closer to the anterior chest wall and will remove the air interface between the heart and the chest wall, and as a result of which the image quality will improve. So in this case, what we are seeing over here, the position of the probe is not changed, but by changing the posture of the heart to left lateral, the image quality has improved. Thank you so much. Thanks for listening and happy Navratri to everyone. I would like to welcome the questions from the participant.
Thank you very much, Dr. Sukharamwala, for such a wonderful presentation. It was indeed really informative one. So far, sir, we have got a question from Dr. Kruti. Can you send the recording of this webinar, sir? Is it okay to share webinar?
Yeah, I am okay with it.
Okay, sir. I think there is no question in chat box.
When there is no question, it means that everybody understood everything or everybody understood nothing. So what I would suggest is you can ask even silly questions also.
Okay.
See, it's a beginning for, like, if it's a beginning for anybody of them, then even silly questions are welcome because that is how you open up.
Dr. Bharat Chaudhary is asking, can we construct a 3D image like a virtual bronchoscopy?
Yes, it is possible with the help of newly available probes where we can construct the 3D volume of the entire heart, and then that thing has been useful in clinical practice. Like if we are closing the atrial septal defect, the 3D construction of the interatrial septum will help us what type of device to be put. Similarly, for mitral valve also, we have 3D reconstruction of the heart on the echo will help us that which particular leaflet is more disease and how can we repair the valve. So it is already existing.
Dr. Apurva Madia is asking, what is the significance of biphasic aortic continuous wave tracing?
I did not got the question.
What is the significance of biphasic aortic continuous wave tracing? Sir, is it okay if I unmute Dr.
Yeah,
Apurva
yeah,
Madia?
please, please.
Sir, please ask the question. He's still on mute.
See, Miss, are you, do you want to say that
Two downward waves, sir is asking.
two downward waves? See, when we put a continuous wave Doppler across the aortic wall, whether you're going from the parasternal view or whether you're going from the four chamber view, it will vary. Like the stenotic part will be seen below the baseline and the regurgitation region will seen above the baseline when we are doing from the four chamber view. But like when we are doing it from the, are we talking of the Doppler, right? So
Yes,
like
sir.
from the parasternal view, the stenotic portion will be seen above the baseline and the regurgitant portion will be seen below the baseline. Like, so if you have waves on the either side, it means that you have stenosis as well as regurgitation simultaneously. If you have waves on the either side, then it could be a regurgitation or the stenosis depending upon the what view you are seeing.
Uh, it's like two downward waves in systole, sir is asking.
Two downwards waves in systole could be because of conditions like HOCM, subaortic sub obstructions. If you have obstruction at two different level, you can have two waves.
Okay. I think, sir, that's it. Like, there is no more questions. This Dr. Apurva Madia is commenting like this. We see often in adults, but no literature have found it.
See, basically, we see in adult only because like we have the sclerosed aortic wall. Because of the sclerosis of the aortic wall, the ejection times lengthens up. And because the ejection time lengthens up, you have an early rapid ejection phase where you see a higher peak and later on you see a smaller peak at the end. So that is more commonly seen in adult, and in case of HOCM also you see such type of biphasic wave.
Okay. There is another question from Dr. Advait Akash. Any causes of dagger-like a shape at AV?
Dagger shape is basically a muscular obstruction. When you have muscular obstruction, like in HOCM, you have a dagger shape. At the same time, in case of uh, RVOT stenosis, like in case of tetralogy of Fallot, you will still have a dagger shape enveloping uh, on the valvular stenosis tongue shape. Dagger shape is basically because of the muscular obstruction. You have a initial very high obstruction, and as the systole uh, at the beginning of the systole, it will be a very steep high, and then later on when the myocardium relaxes, the dagger shape portion steeps down.
Can it occur in concentric LVH?
It won't occur in concentric LVH unless and until it causes obstruction.
Okay.
It will be seen in systolic anterior motion of the mitral valve. If you have a SAM associated with LVH, you can have it.
There is another one question from Dr. Vibhuti Ramani. Can you explain about dysplastic pulmonary valve and pulmonary stenosis?
See, normally the pulmonary, when you have a pulmonary stenosis, it will give a characteristic tongue-shaped Doppler wave pattern, and you have a post-stenotic dilatation. That is, the main pulmonary artery will be significantly dilated seen. If you have a pulmonary stenosis which is not associated with the post-stenotic dilatation, which means that there is possibility that the pulmonary wall is dysplastic. The post-stenotic dilatation means that the pulmonary wall is not dysplastic.
Okay. I think there is no more questions in chat box, sir.
Okay. Anybody would like to ask anything? Yeah, okay, then thank you so
Okay.
much.
Thank you,
Should
Dr.
we?
Tukarambala. Thank you, audience, for joining in. Thank you. See you
Thank you
in the
so
next webinar. Thanks. Thanks a
much.
lot.
Thank you so much.
Okay.